picture this. You are sitting in a doctor's office. You're perched right there on the edge of the examination table, and you're trying your absolute hardest not to make that loud, crinkly sound on the paper roll.
Oh, that terrible paper. It makes a noise every single time you shift your weight.
Every single time. So you take a nervous breath, and the doctor steps forward. They press that cold metal disc of their stethoscope right against your bare chest, and they close their eyes.
It's a very specific, intense focus.
It really is. The room goes completely uncomfortably quiet, and you sit there, you're holding perfectly still, maybe breathing just a little shallower than normal. And you can't help but wonder, what exactly are they listening for in there?
Right. What's the secret?
Yeah. Are they just hearing a steady, reassuring rhythm, like a drum beat? Or are they literally listening to physical valves snapping open and closed? Or maybe they're trying to catch some incredibly subtle, hidden murmur that tells a completely different, maybe terrifying story about your health.
It's an incredibly vulnerable position to be in.
It is one of the most universal experiences in modern medicine. I mean, we have all been on that table. Yet for most of us, what happens on the other end of those earpieces is just a complete mystery.
It is a fascinating dynamic, really. That physical examination, that quiet moment with the stethoscope, has been the cornerstone of medical diagnosis for literally centuries.
Centuries?
Yeah. Before we had advanced imaging, before we had blood tests, a doctor's primary tools were their hands, their eyes, and their ears. But you're entirely right that it often leaves the patient entirely in the dark. You are sitting there wondering what secrets your own body is whispering to the person standing in front of you.
And that vulnerability is exactly why we are here today. Welcome to this deep dive into the hidden language of the human heart. Today, our mission is to decode that language for you.
We're going to take you behind the stethoscope.
Exactly. And our guide for this journey is a massive stack of excerpts from Chapter 16 of a legendary medical text. It's called Bates Guide to Physical Examination and History Taking, the 13th edition.
The absolute gold standard.
If you've ever known anyone who went to medical school or nursing school, you know Bates. It's not just a textbook. It is the Bible for teaching medical professionals how to physically examine the human body.
And this particular section, the cardiovascular chapter, is arguably one of the most dense, complex, and beautiful pieces of medical literature you can find.
It's heavy stuff. But we have a very robust set of source material today. We're going to explore the sheer physical three-dimensional anatomy of the heart in the chest. We'll look at the mechanical and acoustic wonders of the cardiac cycle.
The actual physics of what makes a heartbeat audible.
Right. The physics of it. We will uncover the critical clues hidden in a patient's health history, and we'll break down the intricate, almost acrobatic bedside maneuvers that doctors use to diagnose severe heart conditions.
Without ever making a single incision.
Which is wild to me. It's going to be quite the journey. But before we get totally lost in the weeds of ventricles, murmurs, and pressure gradients, we need to establish our foundation.
We need to know why this matters.
Exactly. Why does this matter to you, the listener? Why should you spend the next hour caring about the mechanical acoustics of your own chest?
Well, because your heart is the ultimate engine of your existence.
The ultimate engine.
Right. And understanding how it works, and perhaps more importantly, understanding how it begins to fail, gives you an incredible, almost superpower level amount of agency over your own health.
I love that word, agency.
It's vital. When you understand the basic mechanics of this pump, it completely demystifies all that intimidating medical jargon that gets thrown around in clinics.
It really does. It's like learning a new language.
It helps you understand exactly what your own body is trying to tell you when you feel a sudden flutter in your chest, or when you notice your rings are suddenly fitting a little too tight, or when you get inexplicably winded just walking up a single flight of stairs.
Right, because knowledge is most valuable when it's actually understood and applied. So by the end of this deep dive, the goal is that you will be able to walk into any medical setting feeling empowered, knowing precisely what is happening when that cold metal disc touches your skin.
That's the mission.
Okay, let's unpack this. To understand the sounds this engine makes, we have to start with the blueprint. Where exactly is this engine sitting, and what does its housing actually look like? Because I think most of us has a very simplified, cartoon image in our heads.
We generally do. I mean, if you ask almost anyone on the street to point to their heart, they will predictably take their right hand and press it flat over the far left side of their chest.
Right, over the left breast.
Exactly. But the true functional anatomy is a bit more central, it's a lot more complex, and frankly, a lot more fascinating from an engineering standpoint.
Okay, so where is it really?
The heart sits in a highly secure central compartment called the mediastinum.
The mediastinum?
Yes. The mediastinum is essentially a thick, connective, tissue-lined vault right in the dead center of your thoracic cavity.
See, I was reading about the mediastinum in the Bates excerpts, and it sounds less like a vault and more like the most crowded, overpacked subway car imaginable. There's not just the heart in there.
Not at all. It is highly congested real estate. You have the heart itself, but you also have the great vessels, the massive aorta arching out, the superior and inferior vena cava bringing all the blood back.
It's a massive plumbing junction.
Huge. You have the pulmonary arteries plunging into the lungs, and right behind all of that, you have the esophagus carrying food to your stomach and the trachea carrying air to your lungs.
So it's all packed in together.
Very tightly. And it is all bordered by your lungs on either side, your sternum, the hard breastbone right in the front, and the dense vertebral bodies of your spine in the back.
So it's essentially the master control room housed safely in the center of the ship, armored by bone on the front and back, and padded by lungs on the sides.
A perfect analogy.
But what totally blew my mind was the orientation of the heart within that space. It's not just sitting perfectly upright, facing forward like a Valentine's heart on a greeting card.
Oh, definitely not. The orientation is arguably the most critical piece of spatial awareness a doctor needs to develop. The heart is rotated.
Rotated.
Yes, it is spun slightly on its axis, and because of this rotation, the right ventricle, which is the chamber that pumps blood just a short distance over to the lungs, is actually the most anterior structure in the chest.
Meaning it's in the very front.
Right. That means the right ventricle is sitting right up front, resting almost directly behind your sternum. Together with the main pulmonary artery, it forms this wedge-like structure that sits right behind the bone.
Wait, so if I'm knocking on my own breastbone right now, right in the middle of my chest, I'm essentially knocking on the front door of the right ventricle.
You absolutely are.
That is wild.
And that means the left ventricle, which is the massive, heavily muscled chamber that does the real heavy lifting of pumping blood to your entire body, from your brain to your toes, sits behind the right ventricle and off to the left.
So it's tucked away.
It forms the left lateral margin of the heart. The rotation obscures the left ventricle from the direct front view. And this specific three-dimensional geometry brings us to one of the most important concepts in the entire physical exam, the PMI.
The point of maximal impulse, or the apical impulse, as Bates sometimes calls it. I really love this concept because it takes something so abstract and makes it incredibly tangible.
It's very tactile.
Yeah. I like to think of the heart like a house. The chambers, the atria, and the ventricles are the rooms. The valves are the doors between the rooms. And the left ventricle is this massive, thick-walled, muscular room at the very bottom left of the house.
A very strong room.
Right. And at the very bottom of that room is a tapered, almost bullet-shaped tip, which we call the apex.
Yes, the apex.
During every single heartbeat, as that powerful left ventricle aggressively squeezes to wring the blood out into your massive aorta, the whole heart twists slightly, and that tapered tip actually swings forward and physically taps against the inside of your chest wall.
It's a striking mechanical action. The heart isn't just a static pump. It writhes and twists as it ejects blood. It physically strikes the inner boundary of the rib cage.
You can actually feel it.
A trained examiner can, yes. Or even you, if you know exactly where to probe with your fingertips, you can palpate it. You can literally feel the heartbeat knocking from the inside.
So where exactly do we look for this knock?
In a healthy adult, the PMI is normally found in the fifth intercostal space.
The fifth intercostal space.
That is the fleshy space between your fifth and sixth ribs.
Finding that space actually takes a bit of work. You can't just guess. The text describes how a doctor will find the sternal angle, that little ridge right below your collarbones, slide their fingers over to find the second rib, and then physically count the spaces down. 2, 3, 4, 5.
It requires precise anatomical landmarks, yes. So it's usually in that fifth intercostal space at or just medial to the left midclavicular line.
Okay, and for the listener at home trying to visualize this, the midclavicular line is an imaginary line dropping straight down from the exact middle of your collarbone.
Exactly.
So if we measure it out from the center of the chest, it is usually about 7 to 9 centimeters lateral to the midsternal line. That's a few inches to the left of your breastbone.
Right.
And what surprised me the most reading the Bates excerpts is how incredibly small this impulse is supposed to be. The text notes that in a supine patient, meaning someone lying flat on their back on the exam table, the diameter of that tapping sensation, the PMI, is normally only about 1 to 2.5 centimeters.
It's tiny.
It is roughly the size of a quarter.
That small size is highly indicative of a healthy, tightly wound, efficient left ventricle. If we step back and connect this microscopic detail to the bigger picture, you start to see why this specific anatomy matters so much to a diagnostic physician.
Because it's a baseline.
Exactly. And knowing the normal location, the normal size, and the normal character of that tiny PMI allows the doctor to instantly detect when something has gone mechanically wrong with the engine.
The body gives us clues by altering its geometry.
Perfectly said. For instance, consider what happens when that PMI moves out of place, or when it gets significantly larger than that 2.5 centimeter quarter.
And this is where the detective work really begins. The text specifically points out that if a doctor feels a PMI that is greater than 2.5 centimeters, say it feels like the size of a golf ball or even larger, that is strong evidence of left ventricular hypertrophy, or LVH.
Hypertrophy. That simply means the muscle has grown abnormally thick.
Like a bodybuilder.
Exactly like a bodybuilder lifting heavy weights. Their skeletal muscles get larger to handle the load. The heart muscle does the exact same thing when faced with a chronic, heavy load.
Like high blood pressure.
Precisely. If a patient has suffered from unmanaged high blood pressure for 10 years, that left ventricle has been forced to pump against a massive amount of resistance every single second of every single day. The muscle wall thickens to compensate.
That makes total sense.
Or, alternatively, the patient might have a dilated cardiomyopathy, where the heart muscle becomes stretched out, enlarged, and weak.
So it bags out.
Yes. In either case, the heart dilates and changes shape. And when it changes shape, that tapping point, the PMI, shifts laterally. It moves further to the left, sometimes wrapping all the way around to the anterior axillary line.
Which is basically near your armpit.
It is.
So the doctor places their hand on your chest, expecting to feel the quarter-sized tap in a very specific spot. And instead, they feel a huge heaving thud way over by your armpit.
Right.
Instantly, before they've even asked you a single question or looked at an ultrasound, they know your left ventricle is enlarged. That is wild.
It is the elegance of the physical exam. And it works for the right side of the heart, too.
Oh, right. Because we established earlier that the right ventricle sits right up front, immediately behind the sternum.
Yes. Normally, you don't really feel the right ventricle beating because it's a lower pressure system.
Yeah.
But if a doctor places the heel of their hand against your lower left sternal border and feels a strong, sustained lifting impulse, what we clinically call a heave or a lift, they know instantly that the right side of the heart is struggling.
Aye.
The right ventricle has become enlarged and is actively pushing against the chest wall with abnormal force.
Bates points out something really interesting about patients with severe lung disease here, too.
Ah, yes, the spatial displacement.
Yeah. In patients with severe COPD, chronic obstructive pulmonary disease, the lungs become chronically hyperinflated. They are trapped full of air. And those massive balloon lungs can actually physically push the entire heart downward in the chest cavity.
The displacement there is profound. In a patient with severe emphysema or COPD, the doctor might palpate the normal spot for the PMI on the chest wall and feel absolutely nothing.
Because the heart isn't there anymore.
It's been pushed down. They have to move their hands down into the epigastric area, right below the rib cage in the upper stomach area, to actually feel the right ventricular hypertrophy pulsing against their fingers from a downward angle.
You are literally feeling the physical geometry of an organ change based on a disease that started in the lungs. Everything is connected.
It's an incredible system.
And speaking of geometry, I have to bring up this incredibly rare, mind-bending condition mentioned in the text. Dextrocardia with situs inversus.
Oh, a fascinating embryological anomaly.
It's like something out of science fiction. It is a rare congenital condition where during fetal development, the entire heart is flipped to the right side of the chest. It's almost like a perfect mirror image of normal anatomy.
And in full situs inversus, even the other major organs are flipped. The liver, normally on the right, grows on the left. The stomach, normally on the left, goes to the right.
So in a patient like that, the PMI, that tapping apex, would be found on the right side of the chest.
It would. It just highlights how adaptable, weird, and sometimes totally surprising human anatomy can be.
It's a stark reminder never to make absolute assumptions.
Never. You must examine the patient in front of you. But once we understand where this engine is located, how it sits in the chest, and how its physical shape can warp under stress, we have to understand the mechanics of how it actually runs.
And that brings us to the actual noises it generates. So let's transition from the blueprint to the acoustics. because everyone knows the lub-dub.
The universal sound of life.
Every school child learns that a heart goes lub-dub. It's the universal sound of being alive. But I don't think most of us know what's actually causing that sound. Are those the muscles squeezing? Are those the valves slamming?
To understand it, we have to look at the two main alternating phases of the cardiac cycle, systole and diastole.
Systole and diastole.
We must define those terms clearly, as they are the bedrock of cardiology. The cardiac cycle is the complete mechanical and electrical movement of the heart from the beginning of one beat to the beginning of the next. Systole is the period of ventricular contraction. This is the active high-energy phase. This is when that massive left ventricle is aggressively squeezing, wringing itself out, building up immense internal pressure to force blood out through the aortic valve and into the systemic circulation.
And diastole?
Diastole is the period of ventricular relaxation. The ventricle stops squeezing and begins to relax. The pressure inside the chamber drops rapidly, creating a slight vacuum effect, and it fills back up with blood from the atrium above it. It's prepping and stretching for the next squeeze.
Going back to our engine analogy, during systole, the engine is firing its pistons. During diastole, the engine is relaxing and refilling with fuel.
That's a great way to picture it.
And it's the sequence of the doors in our house, the internal valves opening and closing during these two distinct phases, that gives us our sounds.
Exactly.
The lub is known in medicine as S1, the first heart sound. The dub is S2, the second heart sound.
That is the sequence. Let's walk through the mechanics of S1, the lub. As the left ventricle starts to contract at the very beginning of systole, the pressure inside that chamber rapidly skyrockets.
It shoots way up.
Within milliseconds, the pressure in the ventricle exceeds the pressure in the left atrium sitting right above it.
And fluid always wants to move from high pressure to low pressure.
Always. It's basic physics. So the blood naturally tries to surge backward into the lower pressure atrium, but that sudden backward surge catches the leaflets of the mitral valve, the door between the atrium and the ventricle like wind catching a parachute.
Oh, like a parachute.
Yes. The mitral valve snaps forcefully shut, sealing the doorway and preventing the blood from flowing backward. And at the exact same time on the right side of the heart, the tricuspid valve snaps shut to prevent backflow into the right atrium.
So both of those entry doors close at once.
The abrupt closing of these two atrioventricular valves, the mitral and the tricuspid, produces the sound we call S1, the lub.
Okay, so the lub is the entry door slamming shut. Then the ventricle keeps squeezing. The pressure gets so incredibly high that it blows open the exit door, the aortic valve, and the blood rushes out to the body. Then what?
Then the ventricle finishes its squeeze and begins to relax. This is the start of diastole. As the ventricular muscle relaxes, the pressure inside the chamber plummets.
It drops off a cliff.
Exactly. Suddenly, the pressure in the massive aorta, which is now stretched full of ejected blood, is much higher than the pressure in the relaxing ventricle.
So the blood tries to fall backward again.
Precisely. Gravity and pressure gradients cause the blood in the aorta to fall backward toward the heart. But again, that backward flow catches the leaflets of the aortic valve and snaps them tightly shut.
And that snap is the dub.
That snapping shut of the aortic valve, along with the pulmonic valve on the right side of the heart, creates the second heart sound, S2, the dub.
Lub-dub. Entry doors slam. Exit doors slam. Makes perfect mechanical sense. But Bates points out something that really shifted my perspective on this. These sounds aren't just the physical leaflets of the valves slapping together like wooden doors hitting a door frame.
No, that's a massive oversimplification.
It's so much more than that.
It's a common misconception, even among early medical students. S1 and S2 arise from vibrations emanating from the valve leaflets, certainly, but also from the tensing of the adjacent cardiac structure.
The structures around the doors.
Right, the muscle walls, the fibrous rings holding the valves, and the turbulent flow of the blood itself as it responds to these massive sudden shifts in pressure gradients. Think of it less like a wooden door slamming, and more like a heavy canvas sail suddenly snapping taut in a gale force wind.
A sail snapping in the wind. That is a great visual.
It is an acoustic resonance of the entire apparatus coming to a sudden high-tension halt.
It is a whole symphony of microscopic vibration. And here is where it gets incredibly cool. We've been talking about S1 and S2 as single unified sounds, lub and dub. But the heart is actually two pumps glued together, a right side and a left side, and they do not operate in absolute perfect microscopic synchrony.
They absolutely do not. And this slight asymmetry creates one of the most elegant auscultatory findings in medicine.
Tell me about it.
Well, the left side of the heart is a high-pressure system pumping to the whole body. The right side is a low-pressure system pumping only next door to the lungs. Because of this, the second heart sound, S2, is actually made of two distinct components.
A2 and P2.
Exactly. A2, which is the closing of the aortic valve on the left, and P2, the closing of the pulmonic valve on the right.
Normally, they slam shut so close together in time that our human ears just process it as one single dub. But if a doctor listens closely to a patient's chest, specifically up in the second and third left intercostal spaces, while the patient is just breathing normally, they can hear a phenomenon called physiologic splitting.
The split, S2. It is a beautiful demonstration of cardiopulmonary interaction.
How does the breathing change the sound?
When you take a breath in, your large diaphragm muscle drops downward. This action creates a negative pressure, a vacuum effect in your chest cavity to pull air into your lungs.
But that vacuum doesn't just suck in air, it acts on everything inside the chest.
It does. That negative intrathoracic pressure also acts like a vacuum on your major veins. It literally pulls a larger volume of venous blood up from your liver, your abdomen, and your arms and sucks it into the right side of your heart.
So during a deep breath in, your right atrium and right ventricle suddenly fill with a significantly larger volume of blood.
Right.
And because there is more blood in the right ventricle, it takes the pump a tiny fraction of a second longer to wring all that extra blood out.
Exactly. This longer ejection time mechanically delays the closure of the pulmonic valve, P2. Furthermore, the text introduces a wonderful concept here called hangout time.
Hangout time. I had to highlight that in the text. It sounds so casual, like the blood is just chilling at the mall. It's not a term you expect in a dense cardiology textbook.
It is remarkably descriptive, though. Hangout time refers to a delay caused by the capacitance of the vascular bed itself. The pulmonary arteries, which carry blood from the right heart to the lungs, are highly distensible.
They're stretchy.
Very stretchy. They are highly compliant, low-pressure pipes, especially compared to the thick, rigid, high-pressure aorta on the left side. Because they are so stretchy, they accommodate the blood easily and don't immediately push back.
So they sort of absorb the pressure wave.
They do. This compliance further delays the pressure backwash that eventually snaps the pulmonic valve shut.
So because of the extra blood volume and the stretchy pipes, the right-sided valve closes just a little bit later than the left-sided valve. During inspiration, A2 happens, and then a fraction of a second later, P2 happens.
You hear a split sound.
Instead of lub-dub, it sounds like lub-drup.
Lub-drup. That is an excellent phonetic representation. And then, when the patient exhales, the negative vacuum pressure goes away. The blood volumes in the left and right sides equalize, the ejection time synchronize, and A2 and P2 fuse back together into a single, crisp S2 sound.
It is a beautiful, entirely normal physiologic rhythm that is subtly altering its beat with every single breath you take from the moment you are born until the moment you die.
It's remarkable.
The machinery is so perfectly balanced. But, as Bates painfully details, not all extra sounds are normal. The text dives deep into pathological sounds, specifically the infamous S3 and S4.
Extra sounds in an adult heart are usually major red flags.
Yeah. If a normal S1 and S2 sound like lub-dub, and S3 adds an extra beat at the end, making the rhythm sound like lub-dub-ta, and S4 adds an extra beat at the beginning, making it sound like to lub-dub.
And it is crucial to understand that S3 and S4 are not valve sounds.
They're not doors slamming.
No. They are the sounds of the ventricular muscle itself struggling and vibrating under duress. Let's look at the S3 first. We know that immediately after S2, diastole begins. The mitral valve swings open, and a rush of blood pours from the atrium down into the ventricle to fill it.
Right, the refilling phase.
Now imagine a patient with systolic heart failure. Their left ventricle is dilated. It's stretched out like an old balloon. It's weak. And because it couldn't pump effectively on the last beat, it is already partly full of leftover stagnant blood.
Oh, man.
When the mitral valve opens and the new blood rushes in during early diastole, it plunges down and violently hits the stagnant pool of leftover blood and the overly compliant flabby ventricular wall.
The text describes it as causing a rapid, abrupt deceleration of the blood column. It is the acoustic equivalent of a wave of water crashing violently into a brick wall.
A very apt metaphor. That sudden tensing of the entire ventricular structure, caused by the blood abruptly stopping, produces a low-frequency vibration. That is the third heart sound, S3.
The S3 gallop.
Yes. Clinically, because of the cadence it creates, it is often referred to as an S3 gallop. In medical mnemonics, it's sometimes taught as the rhythm of the word Kentucky. Kentucky. S1, S2, S3.
It's fascinating because Bates points out that context is everything here. If you hear an S3 in a young, healthy athlete, or a pregnant woman, or a child, it can be completely normal.
Entirely normal.
In those cases, it's just the sound of very vigorous, healthy, rapid filling of a highly compliant ventricle. The blood is just rushing in so fast it vibrates the healthy walls. But if you hear that exact same sound in a 70-year-old man,
It's a massive alarm bell for volume overload, congestive heart failure, and a failing pump. Context dictates pathology.
and then we have the S4, which happens the exact opposite end of diastole, literally just milliseconds before the next S1 begins.
Yes, or gallop.
The Tennessee rhythm. S4, S1, S2.
Correct. The S4 marks the moment of atrial contraction. During most of diastole, blood just falls passively from the atrium into the ventricle, but right at the very end of diastole, the atrium gives one final active muscular squeeze.
The atrial kick.
Sometimes called the atrial kick, yes. It forces the last 20% of the blood down into the ventricle to top it off.
It's like trying to pack that last little bit of clothing into an already full suitcase.
Exactly. Now, if that receiving ventricle has become thick, stiff, and non-compliant, perhaps due to decades of chronic hypertension thickening the muscle, or perhaps it is scarred and rigid from a recent heart attack, it stubbornly resists that final push of blood.
So the atrium has to push harder.
Much harder. The atrium has to contract with immense force against this stiff, unyielding wall. The blood is forced into a stiff chamber, generating a low-frequency, thudding vibration. That is the S4.
So S3 is a problem of too much volume hitting a floppy ventricle. S4 is a problem of pressure hitting a stiff ventricle.
A great summary.
So to bring back our house analogy, an S3 is what happens when the floorboards of the bottom room are rotting and sagging and the water crashes into them and pools up. And S4 is what happens when the floorboards have turned to solid, unyielding concrete and the water smashes against it.
A perfect extension of the analogy.
Which perfectly transitions us into our next major topic. We've talked extensively about the sounds of the walls vibrating and the doors slamming shut. But what happens when the plumbing itself gets noisy? When the water doesn't flow cleanly? Let's dive into decoding murmurs.
Murmurs are perhaps the most famous and often the most anxiety-inducing of all cardiac physical findings.
They really are. Simply defined, a murmur is a heart sound characterized by a longer duration than the crisp S1 or S2, and it is caused purely by turbulent blood flow.
Right. Normally, blood flows through the healthy chambers and valves of the heart in a laminar fashion. Laminar flow is smooth, streamlined, silent. It's like a deep, slow-moving river.
But if you throw a massive boulder into the middle of that smooth river, or if you force that river through a narrow, jagged gorge, the water gets chaotic. It bubbles, it froths, it spins around in eddies, and it gets loud.
That is turbulent flow.
And Bates breaks down the two main ways our internal doors, the valves, can cause this turbulence. A valve can become stenotic, or it can become regurgitant.
Let's examine stenosis first. A stenotic valve is an abnormally narrowed doorway. The leaflets of the valve, which should be paper-thin and flexible, become thickened, heavily calcified, and fused together, often due to aging or prior rheumatic fever.
So they get stiff.
They become rigid and refuse to open fully.
Imagine a massive concert ending and thousands of people are trying to leave the stadium, but someone only opened one of the double doors halfway. The pressure of the crowd builds up behind the door, and the flow of people squeezing through that narrow gap gets chaotic, aggressive, and noisy.
A highly accurate comparison. Aortic stenosis is a classic, dangerous example of this. The left ventricle has to generate massive pressures, sometimes double or triple the normal amount, just to force the blood through that tiny calcified opening.
Wow.
This high-velocity jet of blood tearing through the narrowed valve creates a harsh, loud, turbulent murmur.
And the alternative to a stuck door is a leaky door, a regurgitant valve.
Yes, regurgitation. In this scenario, the valve might open fine, but it fails to close completely or seal tightly. The leaflets might be floppy, torn, or stretched apart by a dilated heart.
So when the chamber squeezes and the pressure rises, the blood doesn't just go forward. It leaks backward in a retrograde direction through the incompetent seal.
Mitral regurgitation is a very common example. As the powerful left ventricle squeezes to send blood to the body, a high-velocity jet of blood gets blown backward into the lower-pressure left atrium.
So if a doctor puts a stethoscope on your chest and hears a swoosh instead of a crisp lub-dub, the detective work immediately begins. It is nowhere near enough for a doctor to just write murmur heard in your chart.
No, they have to decode it.
They have to figure out exactly which of the four valves is broken and whether it's stuck or leaky. And Bates lays out a remarkably specific algorithmic methodology for this auscultatory detective work.
It is a systematic process of elimination. First, the clinician must determine where on the chest wall the murmur is loudest. We know the valves project their sounds to very specific anatomical landmarks.
So location is key.
Very much so. Is the murmur loudest at the right second intercostal space near the sternum? That is the classic aortic area. Is it loudest down at the PMI, the apex of the heart? That is the mitral area. Location is the primary clue.
Next is timing. When exactly during the cardiac cycle does the swoosh happen? This requires the doctor to synchronize their ears with their hands.
Correct. The textbook explains how the doctor will actually feel your carotid pulse in your neck with their fingers while simultaneously listening to your heart with the stethoscope.
That tactile correlation is essential. The carotid pulse in your neck happens during systole. It is the direct physical result of the ventricle contracting and pushing blood outward.
Therefore, if the murmur swooshes simultaneously with the feeling of the pulse against the doctor's fingers, it is a systolic murmur. It's happening during the squeeze.
And if the swoosh happens between the pulses during the relaxation phase, it is a diastolic murmur. So if you have a systolic murmur at the aortic area, you are probably dealing with aortic stenosis. If you have a systolic murmur at the mitral area, it's likely mitral regurgitation. It's like a logic puzzle. But it doesn't stop there. Then you have to look at the shape of the murmur.
The shape or the dynamic configuration of the sound intensity over time. Murmurs change volume. Does the murmur start very soft and gradually get louder? That is a crescendo murmur.
Or does it start with a loud bang and trail off into silence?
That is a decrescendo murmur, typical of aortic regurgitation where the backward leak lessens as the pressure in the aorta drops.
And then there's the classic combination, the crescendo-decrescendo murmur.
Yes.
This is the hallmark of aortic stenosis. As the ventricle starts to squeeze, the pressure builds, the murmur gets louder and louder, peaking in mid-systole when the flow is fastest, and then fading away as the ventricle finishes its contraction.
Exactly. And once the location, timing, and shape are determined, we must quantify the intensity or the absolute loudness of the murmur. To ensure standardized communication between doctors, medical professionals use the Levine grading scale for systolic murmurs.
Which is a very specific 1 to 6 scale.
Yes, 1-6.
Let's walk through that Levine scale, because when I read this in Bates, it really illustrated just how acute and highly trained a doctor's hearing has to be. Grade 1 is incredibly faint. It is actually softer than the normal S1 and S2 sounds.
It is easily missed in a noisy clinic. The text says a grade 1 murmur might only be heard in a perfectly quiet room by an experienced listener who is actively tuning everything else out and concentrating intensely.
Grade 2 is quiet, but it is heard immediately when you place the stethoscope securely on the chest. Grade 3 is moderately loud, roughly the same volume as the normal heart sounds.
And then we reach what I think is the most fascinating leap in the physical exam, the jump from grade 3 to grade 4.
Bates emphasizes this as a critical diagnostic threshold, because a grade 4 murmur isn't just louder than a grade 3. A grade 4 murmur introduces an entirely new sensory experience, a palpable thrill.
The thrill. It is a remarkable, undeniable physical finding.
It sounds intense.
It is. If a murmur is graded as a 4 or higher, it means the turbulent blood flow tearing through that diseased valve is so incredibly violent, so intensely chaotic, that the acoustic energy actually vibrates right through the heart muscle, travels through the fluid and tissue of the mediastinum, reverberates through the bone of the ribs, and buzzes against the surface of the skin.
You can literally feel the sound with your bare hand. Bates equates the sensation to feeling the buzzing throat of a deeply purring cat.
The technique requires the doctor to press the padded, fleshy area of their palm, the ball of the hand near the wrist, firmly against the chest wall over the heart. If there's a grade 4 murmur, you can feel this distinct, mechanical, high-frequency buzzing against your skin.
It's like resting your hand on a vibrating motor.
It is a profound, tactile manifestation of disturbed fluid dynamics. If a clinician feels a thrill, they automatically, without question, know the murmur is severe and is at least a grade 4.
What about grade 5 and 6?
Grade 5 is even louder, still accompanied by a strong thrill, and can be heard with the stethoscope partially tilted off the chest. And grade 6, the highest level, is so violently loud that the acoustic energy projects outward. You can hear the murmur with the stethoscope hovering just above the skin, not even touching the patient.
Well, that is just terrifying to imagine blood moving with that much force. But doctors don't just assign a number, they also assign quality descriptors to the murmur. They try to capture the actual texture of the noise.
Yes, the qualitative adjectives are vital clues. Is the murmur a high-pitched, smooth blowing sound? Is it harsh, grating, and raspy? Is it a low-pitched, heavy rumbling sound, which you classically hear in mitral stenosis? Or is it vibratory and musical, like a plucked string?
These descriptive words might sound a bit subjective, almost like a wine tasting, but Bates is clear that they're highly correlated with specific, concrete anatomical defects.
Absolutely.
A harsh, grating murmur strongly implies incredibly high pressure forcing blood past a rigid, heavily calcified, rock-like obstruction. A blowing murmur implies a high-velocity, slender jet of blood leaking backward through a small gap. The sound perfectly mirrors the physics of the lesion.
It does. But before we leave the topic of murmurs, we must address a very common scenario that causes immense patient anxiety.
I am so glad you brought this up. I want to take a second here to talk directly to you, the listener, because if you are sitting in a quiet doctor's office and the doctor takes the stethoscope off your chest, looks at you and says, "Well, I hear a heart murmur," it is incredibly universally easy to panic.
The mind instantly jumps to open heart surgery.
Exactly. Valve replacements, worst-case scenarios. But Bates makes a very comforting, statistically significant point here. Almost everyone, at some point in their life, will have an audible heart murmur.
This is a crucial public health clarification regarding what we call innocent or physiologic flow murmurs.
Innocent murmurs.
Yes. In children, in healthy young adults, or particularly during pregnancy, the human body is often in a hypermetabolic state. The heart is required to pump a significantly larger volume of blood at a much faster rate to meet the body's demands.
The engine is just revving higher.
Precisely. And this high velocity, massive volume of flow moving rapidly across completely normal, perfectly healthy, structurally sound valves can create enough natural turbulence to generate an audible swooshing sound.
That makes a lot of sense.
This is a functional, innocent systolic murmur. It is not pathological. It does not indicate structural disease. It is simply the acoustic byproduct of a robust, powerful engine moving a lot of fluid very quickly.
Therefore, hearing the word murmur from your doctor is a physical exam finding. It is a clue. It is not, in and of itself, automatically a diagnosis of disease.
A very important distinction.
That is such a relief to hear. A murmur is a clue, not a death sentence. And to gather more clues, we have to look beyond the mechanical plumbing, the doors and the chambers, and dive into the wiring that actually controls them. Let's move to the electrical grid and the math of the pump. Because the heart isn't just a dumb mechanical sack of muscle.
Far from it.
It has its own built-in, highly sophisticated electrical conduction system that dictates the rhythm and timing of every single beat.
The electrical synchronization of the human heart is an absolute biological marvel. The entire process of a heartbeat originates spontaneously in a tiny cluster of specialized pacemaker cells located high up in the wall of the right atrium.
The sinus node.
Yes, this is the sinoatrial node or the sinus node. Automatically, autonomously, without you ever having to consciously think about it, this tiny node generates and discharges an electrical impulse anywhere from 60 to 100 times every single minute.
It is the biological spark plug. It fires and the engine turns over.
Yes. The moment that spark is generated, the electrical impulse sweeps rapidly like a wave across the muscular walls of both the right and left atria. This electrical wave causes the muscle cells to depolarize and physically contract, squeezing the blood down into the ventricles.
And then what happens to the signal?
The electrical signal then travels down to a relay station called the AV node, the atrioventricular node, which is located lower down in the tissue separating the atria from the ventricles. And here, at the AV node, something absolutely essential to human survival happens. The electrical impulse is deliberately, measurably delayed.
I read about that delay, and it is so brilliantly engineered. The AV node grabs the electrical signal and holds onto it for just a fraction of a second. It pauses the electricity just long enough to allow the atria to physically finish squeezing their load of blood down into the ventricles before the ventricles get the electrical command to contract.
If that delay did not exist, if the signal just passed straight through, the atria and the ventricles would contract simultaneously.
Which would be bad.
Very bad. They would essentially be fighting against each other, squeezing blood against closed valves. The efficiency of the pump would plummet, leading to severe hemodynamic compromise.
But because of that perfectly timed pause, the ventricles fill completely. Then, the AV node releases the signal, and it races down the main highway, the bundle of His, and splits into the right and left bundle branches, spreading with incredible speed through the massive muscular walls of the left and right ventricles.
This rapid dissemination causes the massive ventricular muscles to contract forcefully and simultaneously, beginning at the bottom apex and wringing the blood upward and outward into the aorta and pulmonary arteries.
It's a beautifully choreographed electrical cascade, from the sinus node spark to the atrial wave to the AV node pause to the massive ventricular depolarization.
And that cascade is exactly what a doctor is looking at when they print out an electrocardiogram or an ECG. The waves on the paper perfectly mirror the electrical path in the heart.
So that is the intricate electrical grid governing the timing. But how do doctors measure the actual physical output of this pump? How do they know if the engine is actually moving enough fuel? Bates introduces a very specific foundational mathematical equation for this.
Yes.
Cardiac output equals heart rate multiplied by stroke volume.
It is the fundamental equation of hemodynamics. Heart rate is the simple variable, beats per minute. If you are resting, maybe it's 70 beats. But stroke volume is where the complex, heavy physiology comes into play.
How do we define stroke volume?
Stroke volume is defined as the exact absolute volume of blood in milliliters that the left ventricle forcefully ejects out into the aorta with each single individual heartbeat.
So if your heart beats 70 times a minute and it ejects 70 milliliters of blood with each beat, you multiply those and your cardiac output is 4,900 milliliters. That means your heart pumps nearly 5 liters of blood, basically your entire blood volume through your entire body every single minute.
The math is staggering.
It is a tireless machine. But the volume it ejects, the stroke volume, is not a fixed number. It is highly variable, and it is governed by 3 primary physiological pillars: preload, myocardial contractility, and afterload.
These are not just academic terms. Fully grasping these 3 concepts is the absolute foundation for understanding how and why heart failure occurs.
Let's break them down one by one, starting with preload.
Preload refers to the physical load, the volume of blood that stretches the cardiac muscle before it begins to contract. Specifically, it is the volume of blood distending the left ventricle at the very end of diastole, right before systole begins.
To make sense of this, I love the slingshot analogy. Think of preload as pulling back the rubber band on a slingshot. The blood actively filling the heart is the hand pulling the band back.
The Frank Starling law of the heart.
Right. According to that law, the further you pull that rubber band back, meaning the more volume you put in, the more the muscle fibers stretch, the harder and more forcefully it snaps forward when you let go. The heart muscle physically wants to be stretched a certain amount to optimize the strength of its contraction.
Up to a point, that is absolutely true. Increased preload normally equals increased stroke volume.
But taking the slingshot analogy further, if you overstretch that rubber band every single day, pulling it back as far as it can possibly go year after year, eventually the rubber loses its elasticity. It gets worn out, floppy, and it doesn't snap back anymore.
A very precise analogy.
That is exactly what happens to the heart muscle in chronic volume overload. It stretches too far, the fibers break down, and you develop congestive heart failure.
The heart becomes a dilated, floppy sac that can't snap back. The second pillar is myocardial contractility. This is the intrinsic, innate ability of the cardiac muscle tissue itself to shorten and generate force when given a load. It is the pure biochemical strength of the muscle fibers.
What changes contractility?
Contractility dramatically increases when your body is under stress, stimulated by adrenaline and norepinephrine from your sympathetic nervous system. Your heart beats not just faster, but harder.
And when does it decrease?
Conversely, contractility decreases rapidly and catastrophically if the heart muscle is starved of oxygen and the tissue dies, which is the exact pathological process of a myocardial infarction, a heart attack. Dead tissue cannot contract.
And the third and final pillar governing stroke volume is afterload. If preload is the stretch of the rubber band before the squeeze, afterload is the resistance the heart must actively pump against during the squeeze.
Correct. Afterload is essentially the degree of vascular resistance in the systemic circulation. It is dictated by the stiffness and tone in the walls of the massive aorta, the large branching arteries, and the millions of tiny peripheral arterioles throughout your entire body.
To visualize afterload, think of it like trying to push open a heavy solid oak door to leave a room. If the door's hinges are well oiled and it swings open freely into an empty hallway, that is low afterload. The heart doesn't have to work hard at all to push the blood out.
But what if there's someone standing on the other side of that door?
Exactly. Leaning their entire body weight against it, trying to keep it closed.
That opposing force represents high vascular resistance. That is chronic high blood pressure.
If you have severe high blood pressure, the heart has to violently shove with all its might just to get that heavy door open, far enough to push the blood out into the aorta. The heart has to overcome that massive resistance on every single beat. Over time, pushing against that high afterload causes the heart muscle to thicken, hypertrophy, and eventually stiffen and fail.
And when a cardiologist evaluates how well a patient's pump is managing these three forces, preload, contractility, and afterload, they rely heavily on a metric called the ejection fraction, or EF.
The ejection fraction is simply the percentage of the total ventricular blood volume that is actually ejected during each heartbeat.
And it's important to note that a healthy heart doesn't empty completely dry like a wrung-out sponge.
No, it leaves some behind.
It does. A normal, healthy ejection fraction is around 60%. The ventricle fills, and it pumps out roughly 60% of that volume, leaving 40% behind as a reserve.
But Bates makes a really vital clinical distinction here regarding how we classify heart failure based on this metric.
This is a huge takeaway. Not all heart failure is the same disease process.
Far from it.
Modern cardiology divides heart failure into two distinct clinical entities, which are driven by entirely different mechanical failures. We have heart failure with reduced ejection fraction, often called HFrEF, and heart failure with preserved ejection fraction, or HFpEF.
Let's break those down.
In heart failure with reduced EF, the problem is contractility. The heart muscle has become weak, dilated, and floppy. It acts like an overstretched balloon. It might fill up with a huger volume of blood during diastole, but because the muscle is so weak, it can only muster the strength to pump out, say, 30% or even 15% of that volume. The EF is severely reduced.
And the other kind, HFpEF.
In heart failure with preserved EF, the contractility is technically fine. The heart muscle might be extremely stiff and heavily thickened due to decades of high afterload, high blood pressure. When it squeezes, it still successfully pumps out 60% of the blood that is inside it. The EF is preserved.
But there's a catch.
A major one. Because the walls are so thick and rigid, like our concrete floorboards from earlier, the ventricle couldn't stretch to fill up with very much blood in the first place.
So even though it's pumping out 60%, it's 60% of a tiny little volume. So the total amount of blood reaching the body is still dangerously low.
Exactly. The math fails the patient. And because the underlying mechanical defects are entirely opposite, one is a floppy, weak pump, the other is a stiff, underfilled pump. They require entirely different pharmaceutical treatment algorithms.
It's all about deeply understanding the core mechanics of the pump. But here is the part of the Bates text that absolutely blew me away. Everything we just talked about, the pressures, the fluid status, the right-sided heart failure. A highly skilled doctor can assess almost all of this without ordering an expensive echocardiogram, without sending you to a dark room for an x-ray, and sometimes without even taking their stethoscope out of their pocket.
It's true.
Which brings us to external clues, the JVP and the carotid pulse.
This is where the physical examination transcends basic assessment and truly becomes an art form. We can accurately gauge the deep internal pressures of the heart by looking closely at the external veins and arteries in the patient's neck. Let's begin with the jugular venous pressure, or the JVP.
The JVP is essentially a direct, fluid-filled pipeline straight down into the right atrium of the heart. Because there are no major functioning valves blocking the anatomical pathway between the right atrium in the chest and the internal jugular vein running up the side of your neck, the two are in direct communication.
Whatever pressure changes are happening deep in the right side of the heart are transmitted instantly, straight up into the column of venous blood in your neck. It functions exactly like a glass manometer tube you might use in a physics lab.
The JVP provides a highly accurate, real-time estimate of central venous pressure and right ventricular and diastolic pressure.
But measuring it is a remarkably delicate and difficult bedside skill. The right internal jugular vein lies deep underneath the sternocleidomastoid muscle, that is the thick, prominent muscle that runs diagonally down the side of your neck from your ear to your collarbone.
So the doctor can't actually see the blue vein itself.
No, the vein is hidden deep in the tissue. Instead, the examiner must learn to identify the subtle, undulating pulsations that the vein transmits through the muscle to the surface of the skin.
And to do this, the doctor will dramatically adjust the head of your examination table. The standard starting position described in the text is raising the head of the bed to exactly a 30-degree angle.
Then the doctor will often use a pen light and shine it tangentially, meaning they shine the beam across the neck from the side, parallel to the skin, rather than pointing it straight down.
The tangential lighting is crucial. It casts long shadows and highlights any tiny, flickering, subtle movements rippling just under the skin of the neck.
The examiner is looking for the highest oscillation point, or the meniscus, of the right internal jugular venous pulse. It looks like a tiny flickering flutter right above the collarbone. Once they locate that specific flickering point, they perform a literal bedside geometric measurement.
It is pure geometry. The doctor first locates the sternal angle, that prominent bony ridge on your breastbone where the second rib attaches. They take a standard ruler and place it perfectly vertically, straight up into the air, resting directly on the sternal angle.
Then they take a straight edge, like a rectangular index card, and hold it perfectly horizontally from the highest point of that flickering pulsation in the neck, bringing it over until it intersects the vertical ruler, forming an exact 90-degree right angle.
It seriously looks like they are doing carpentry on your chest. It's so analog and brilliant.
It is analog, but it is incredibly precise. The doctor reads the vertical distance in centimeters where the card hits the ruler. Let's say it reads 3 centimeters. Then they must add a constant of 5 centimeters to that number.
Why do they always add 5 centimeters? What's the significance of that number?
It is a fixed anatomical constant. Regardless of whether a patient is lying completely flat, sitting up at 30 degrees, or sitting upright at 90 degrees, the sternal angle on the chest wall is consistently about 5 vertical centimeters above the center of the right atrium, deep inside the chest.
So, by taking the visible height on the ruler and adding that hidden 5 centimeters, you calculate the total pressure head of blood extending above the right atrium.
Exactly. And a total measurement of more than 8 centimeters is considered clinically elevated.
And an elevated JVP is a massive, glaring red flag. It is highly correlated with both acute and chronic heart failure. It means the fluid is backing up. The right side of the heart is struggling to pump its load into the lungs, the pressure inside the chamber is rising, and that high pressure is literally backing the blood up the pipes, all the way up into the patient's neck.
Yes, but the JVP assessment isn't just about the absolute height of the fluid column, it's also about the morphology, the shape of the waves themselves. When a trained doctor looks at that flickering in your neck, they are not just seeing a random twitch. They are reading complex pressure waveforms visible to the naked eye.
Bates breaks this down, and it's so complex. The jugular venous pulsations are not a simple, single rhythmic beat like the pulse you feel in your wrist. They are a complex, biphasic, double ripple undulation.
The text details the specific waves. First is the O wave. This small upward deflection represents the slight transient rise in venous pressure when the right atrium actively contracts to push blood into the right ventricle.
Okay, the atrial contraction.
Then, a moment later, there is the V wave. This is a larger rise in pressure occurring as venous blood continues to passively fill the right atrium from the body, while the tricuspid valve is closed during ventricular systole.
And interspersed between those rising waves are the inward deflections, the X and Y descents, which correspond to the sudden drops in pressure when the atrium relaxes and when the tricuspid valve opens to let the blood empty.
Precisely.
So you have these intricate double ripples happening in the neck. But how on earth does a doctor know for sure that they are looking at the delicate jugular vein and not just the massive, throbbing carotid artery pulsing right next to it underneath the same muscle?
It is a vital clinical distinction, and Bates provides a clear checklist to differentiate them. The JVP is a soft, biphasic, undulating inward movement. Crucially, it is rarely palpable. If you press your finger lightly on it, you can't really feel it pushing back.
What about position?
Furthermore, the height of the JVP fluid column will drop visibly if the patient is asked to sit more upright, and it will fall dramatically when the patient breathes in deeply, as that negative thoracic vacuum pressure sucks the blood downward into the chest.
The carotid pulse, on the other hand, acts completely differently.
It does. The carotid pulse is a vigorous, high-pressure, single outward thrust. You can easily and distinctly palpate it pushing against your fingers, and its amplitude and height are completely 100% unaffected by whether you sit up, lie down, or take a deep breath.
Speaking of the carotid pulse, that is the other massive diagnostic clue located right there in the neck. After checking the veins for right-sided heart pressures, a doctor will deliberately palpate and auscultate the carotid arteries to gather clues about the left side of the heart and the state of the arterial system.
Let us examine palpation first. The specific contour and the amplitude of the carotid pulse wave are incredibly informative to trained fingers. A normal carotid upstroke the moment the pulse hits your fingers is brisk, smooth, and rapid, immediately following S1. It feels sharp and immediate.
But if a patient has severe aortic stenosis, that stiff, calcified, heavily narrowed aortic valve we discussed earlier, the carotid upstroke will feel noticeably altered. Bates describes it as delayed and weak, sometimes called pulsus parvus et tardus.
Yes, small and late. Because the left ventricle is struggling so immensely to push blood through that tiny calcified opening, the resulting pressure wave that finally reaches the neck is sluggish, prolonged, and lacks that sharp, brisk impact. The doctor can feel the stenosis in the neck before they even place the stethoscope on the chest.
And the text introduces two incredible clinical clues that a doctor can find just by paying close attention to the rhythm and force of the pulse. First is a phenomenon called pulsus alternans.
Pulsus alternans is a grave finding. This is a condition where the underlying rhythm of the pulse is perfectly regular. The beats happen exactly when they are supposed to, but the actual force of the pulse alternates beat to beat.
It literally feels like boom, tap, boom, tap. Strong beat, weak beat, strong beat, weak beat. Bates points out that this almost always indicates severe left ventricular dysfunction. The heart muscle is so fundamentally damaged and depleted of energy that it can only muster a strong, effective contraction every other beat. It has to rest on the intervening beats.
The second major clue is the paradoxical pulse, or pulsus paradoxus. This involves a complex interaction between respiration and blood pressure. Normally, when a healthy person takes a deep breath in, the negative pressure in the chest causes a very slight, almost imperceptible drop in systolic blood pressure, maybe 3 or 4 millimeters of mercury. That is normal physiology.
But if a patient has a paradoxical pulse, that drop is massive. We're talking a drop in systolic blood pressure of 10 to 12 millimeters of mercury or even more just from taking a breath.
And the doctor detects this not just by feeling, but by using a blood pressure cuff. They pump it up and slowly deflate it, listening carefully for when the carot cough sounds. Those are the rhythmic tapping sounds of the pulse breaking through the cuff. Pressure disappear and then reappear in time with the patient's breathing cycle.
It's an intricate maneuver. But why does it matter? What causes a paradoxical pulse?
A paradoxical pulse is a stark, flashing warning sign. It is the classic hallmark finding of cardiac tamponade. Tamponade is a rapidly life-threatening emergency where fluid or blood rapidly builds up in the pericardial sac, the fibrous membrane immediately surrounding the heart.
Crushing it from the outside.
Because the sac cannot stretch quickly, the fluid literally crushes the heart from the outside, preventing the right ventricle from expanding and filling. When the patient breathes in and extra blood tries to rush into the right heart, the right ventricle expands, but because it's trapped by the fluid, it bulges inward, crushing the left ventricle and causing a massive sudden drop in blood pressure.
It's suffocating the heart. And surprisingly, the text mentions you can also see a paradoxical pulse in severe acute asthma attacks, where the massive, violently forced swings in intrathoracic pressure from the patient fighting to move air through swollen airways mechanically impede the heart's output.
Now, before a clinician ever touches your neck to feel for these intricate pulse variations, Bates issues a very stark, very clear clinical warning. There are 2 absolute rules when examining the neck. Rule number 1. Never palpate both carotid arteries at the exact same time.
If you press on both sides of the neck simultaneously, you physically cut off the main arterial blood flow to the brain, and the patient will pass out on the table. Syncope.
Exactly. It is dangerous and serves no diagnostic purpose. And rule number 2 is perhaps even more critical. A doctor must always listen to the carotid arteries with their stethoscope before they ever apply pressure with their fingers.
They were listening for something very specific called a bruit. A bruit is a murmur-like rushing, swooshing sound in the artery, again caused by turbulent blood flow. But in the neck, this turbulence isn't caused by a leaky valve. It is usually caused by an atherosclerotic plaque.
Yes, a buildup of cholesterol, fat, and calcification that is actively narrowing the interior lumen of the artery that supplies blood directly to the brain.
And this is the part of the reading that genuinely terrified me. If a doctor skips the listening step and blindly presses hard on a carotid artery that happens to have a large brittle plaque inside it, the physical pressure from their fingers could dislodge a piece of that plaque.
A terrible complication.
That little piece of atherosclerotic debris will immediately fly straight up the artery, lodge in a smaller vessel in the brain, block the blood flow, and cause an acute ischemic stroke right there on the examination table.
It is an iatrogenic disaster, a complication caused by the medical exam itself. You must auscultate first to ensure the artery sounds clear and safe before applying pressure. And the absolute danger of carotid stenosis cannot be overstated.
Bates cites the NASCENT study here, which is a landmark clinical trial in neurology and cardiology. The statistics they pull from it are sobering.
They are. The study looked at patients who were found to have a 70% stenosis, meaning 70% of the diameter of their carotid artery was blocked by this plaque.
Even if they didn't have symptoms.
For those patients, even if they had only minor symptoms previously, they faced a devastating 24% stroke rate over just the next 1.5 years. Finding that brute with a stethoscope, confirming the stenosis with an ultrasound, and intervening surgically to clean out the artery is a massive, life-saving opportunity to prevent a catastrophic, debilitating stroke.
It is the ultimate preventative detective work. But speaking of detective work, let's step back from the physical examination entirely for a moment. Long before a doctor uses a stethoscope, before they measure your neck veins with a ruler, before they feel your pulse, they talk to you. Let's move to the interview. Decoding the health history.
The health history is arguably the most important, high-yield component of any medical encounter. All the physical exam maneuvers we've discussed are often just used to confirm the suspicions generated during the interview.
It sets the stage.
A highly skilled clinician is trained to take the myriad of disorganized, sometimes vague symptoms a patient might report and rapidly categorize them to answer 3 fundamental physiological questions about the cardiovascular system.
Bates breaks these 3 questions down beautifully. Number 1, is the blood supply to the heart muscle itself adequate? Number 2, is the electrical conduction system of the heart functioning normally? And number 3, is the heart adequately moving blood through the circulation to supply all the other organs?
It boils down to assessing the plumbing, the wiring, and the mechanical pump. And the most common symptoms patients complain of mapped directly to those 3 systems: chest pain, palpitations, shortness of breath, edema, and syncope, which is fainting. Let's start with the most alarming one: chest pain.
The text notes a statistic that blew my mind. Chest pain accounts for a full 1% of all primary care outpatient visits. That sounds like a small percentage, but when you consider millions of visits, that is a massive number of people walking into clinics worried about their hearts.
It is incredibly common, and it is the absolute classic symptom of coronary heart disease, which currently affects over 15 million Americans. Because the stakes are so high, when a patient reports chest pain, the clinician must assume it is a life-threatening acute coronary syndrome, a heart attack, where the blood supply to the heart muscle is blocked until they can definitively prove otherwise.
You can't just send them home with antacids.
Absolutely not. The literature is very clear. Inappropriate discharge from an emergency room for a missed acute myocardial infarction carries a horrifying 25% mortality rate. The patient will likely die.
Classic chest pain, the kind you see in movies, is often described as a heavy, crushing pressure. An elephant sitting on the chest, pain radiating down the left arm or shooting up into the jaw, usually brought on by physical exertion and relieved by rest. But Bates highlights a critical, often misunderstood, highly dangerous fact here regarding how these symptoms actually present in the real world. Not everyone gets the classic Hollywood heart attack symptoms.
This is perhaps one of the most vital public health messages contained in the text. The literature emphasizes heavily that women, particularly those over the age of 65, are significantly more likely to present with atypical symptoms of acute coronary syndrome. They might not experience that classic crushing central chest pressure at all.
Instead, they might report symptoms that seem entirely unrelated to the heart. They might complain of a sharp pain in their upper back, between their shoulder blades. They might have a nagging pain in their neck or jaw. They might experience sudden, unexplained bouts of nausea or vomiting. Or they might simply complain of a profound, overwhelming, paralyzing fatigue that comes out of nowhere.
This divergence in symptomatology is incredibly dangerous. If an older woman walks into a busy, chaotic emergency room complaining that her upper back hurts and she feels nauseous, it is tragically easy for rushed medical staff to dismiss her symptoms as a pulled muscle, indigestion, or a mild stomach bug.
It's terrible.
The failure to rapidly recognize these atypical symptoms in women leads directly to misdiagnosis, severely delayed treatment, and higher mortality.
It is a systemic issue in medical recognition that is finally getting more attention, and Bates goes even deeper into this. The text points out that roughly half of all women who experience angina heart pain and who undergo a cardiac angiogram will actually have seemingly normal, completely open major coronary arteries. The big pipes are clear.
Yes, the macroscopic plumbing looks fine. In many of these cases, their pain is caused by microvascular coronary dysfunction. This is a disease process affecting the tiny, microscopic branching vessels deep within the heart muscle that simply do not show up on standard imaging tests. The ischemia, the lack of oxygen, is very real, and the pain is very real, but it requires highly specialized testing to prove.
It requires the doctor to thoroughly validate the patient's symptoms rather than just dismissing them because the main arteries look clear.
Precisely.
The second major symptom category the interview focuses on is shortness of breath. And again, doctors use very specific terminology to decode exactly what the patient is feeling and when they are feeling it. There's generic dyspnea, which is defined as an uncomfortable, inappropriate awareness of breathing given the level of exertion. But then there are vital positional clues, like orthopnea.
Orthopnea is a heavily tested concept in medical training. It is dyspnea that occurs specifically and exclusively when the patient is lying flat on their back, and it rapidly improves when they sit up.
The mechanics of this are fascinating.
They are purely fluid dynamics. If a patient's left ventricle is failing, it cannot pump blood effectively forward. During the day, while they are standing or sitting, gravity pulls the excess fluid down into their legs. But when the patient goes to bed and lies flat, all that accumulated fluid in their lower extremities suddenly shifts back into the central venous circulation.
And the failing heart can't handle it.
The failing left heart simply cannot handle this sudden, massive influx of volume. Consequently, the pressure backs up retrograde into the pulmonary veins, causing pulmonary edema. The fluid literally leaks out of the capillaries and into the microscopic air sacs of the lungs.
So the patient literally feels like they're slowly drowning when they lie down. It's terrifying. To capture this in the interview, doctors will actually quantify the severity of the orthopnea by asking a very specific, practical question. How many pillows do you sleep on at night?
It is a brilliant, practical metric. If a patient says they used to sleep completely flat on one pillow, but over the last 3 months they have slowly had to prop themselves up on 3 or 4 pillows just to avoid feeling suffocated, that is a massive, quantifiable red flag for progressive left-sided heart failure.
Another terrifying variation of this positional breathing issue is paroxysmal nocturnal dyspnea, or PND.
PND is dramatic and frightening for the patient. This isn't just struggling to catch your breath when you first lie down. In PND, a patient lies down, falls asleep relatively comfortably, but then 1 to 2 hours later, they're suddenly violently awakened from sleep, gasping for air, feeling as though they are being smothered. They are forced to sit bolt upright in bed or even stand by an open window just to get air.
It is a sudden, acute, nighttime decompensation of the fluid balance in the lungs. And speaking of fluid balance, that leads us directly to the next major symptom category, edema, or swelling.
Edema is the classic sign of right-sided heart failure. If the right side of the heart is failing, it cannot effectively push venous blood forward into the lungs. The pressure backs up into the systemic venous system of the entire body. Gravity pulls that high-pressure fluid downward, forcing it out of the blood vessels and into the tissues, leading to dependent edema swelling in the lowest body parts, which is usually the feet, the ankles, and the lower legs.
But what is truly remarkable, and frankly deeply alarming, is the hidden capacity of the human body to store this excess fluid before it ever becomes obvious to the patient or the doctor. Bates drops a fact here that I had to read 3 times to believe. The interstitial tissue, which is the microscopic spaces between the cells in your body, can silently absorb up to 5 liters of fluid before visible swelling occurs.
Yes, 5 liters. For an average adult, that is roughly a 10% gain in total body weight. A patient's failing heart can cause them to retain all that fluid, soaking it up like a massive internal sponge. Before visible, pitting edema even appears on their shins.
5 liters. That is the equivalent of 2.5 large 2-liter soda bottles of water just hiding in your tissues. This is exactly why cardiologists emphatically tell their heart failure patients to weigh themselves on a scale every single morning. A rapid weight gain of 1 to 2 pounds in a single 24-hour period is a surefire sign of dangerous fluid retention, and it happens long before their ankles ever start to swell.
It highlights why the history taking must be so subtle and probing. A good doctor won't just ask, are your ankles swollen? They will look for the hidden fluid. They will ask, are your rings getting difficult to take off your fingers? Do your shoes feel unusually tight by the end of the day? Have you noticed your clothes feeling tighter around your midsection? Or have you had to let out your belt a notch recently? These specific, everyday questions probe for that hidden, progressive fluid accumulation.
So bringing this back to our listener, what does this all mean for you when you go to the doctor? It means that you need to be hyper-specific and quantify your symptoms. Don't just walk in and say, I'm feeling more tired lately, or I'm a little short of breath sometimes. Those are too vague.
Vague complaints lead to vague diagnoses.
Right. You have to quantify it for them. Tell them exactly what has changed. Say, 3 months ago, I could easily walk up the 2 flights of stairs to my apartment carrying groceries with no problem. Today, I had to stop on the first landing drop the bags, and rest for 2 minutes because my chest feels uncomfortably tight and I simply cannot catch my breath.
That phrasing is perfect. Quantifying your baseline level of activity and establishing precisely when and how the symptoms change provides the clinician with the critical, actionable data they need. It allows them to accurately assess the current severity of the disease and decide on the immediate, necessary next steps for testing and treatment.
All right, we have covered an incredible amount of ground. We've mapped the anatomy, decoded the mechanical sounds, understood the pressure gradients, and learned how to translate the interview. Now for our final segment, let's pull all of this incredible science together back at the bedside. Let's look at the art of the exam, maneuvers and the stethoscope. How does the doctor physically extract all these subtle acoustic clues from your chest?
It requires a highly systematic approach practiced thousands of times and an intimate physical understanding of the primary tool, the stethoscope itself. A standard, high-quality cardiology stethoscope has two distinct sides on its chest piece. The bell, which is the smaller, hollow, cup-like side, and the diaphragm, which is the larger, flat, disc-like side covered by a stiff membrane. They're engineered to detect entirely different sound frequencies.
The diaphragm is your high-frequency tool. When the doctor uses the big flat side, they press it firmly and flatly against your chest wall. It is designed to pick up relatively high-pitched sounds. S1 and S2, the classic lub-dub, are high-pitched. The harsh, grating murmurs of aortic stenosis or the high-velocity blowing murmurs of regurgitation are high-pitched.
The bell, conversely, is highly sensitive to low-pitched sounds, but it requires a completely different physical technique. You must apply the bell very lightly against the skin, resting it there with just barely enough pressure to create a full air seal with its outer rim. The bell is absolutely essential for hearing the low-frequency, thudding sounds of an S3 or an S4 gallop, or the deep, low-pitched rumbling murmur of mitral stenosis.
And there's a brilliant, almost magical physical trick to this that Bates points out in the expert technique section. If a doctor is using the bell to listen for a faint S3, but they accidentally press the bell too firmly against the patient's skin, they ruin the acoustics.
They do. By pressing firmly, they stretch the underlying skin tight across the rim of the bell. That taut skin acts exactly like a tight drumhead, and it physically, mechanically converts the hollow bell into a diaphragm. If you do that, the low-pitched sounds you are searching for, the S3 or S4, will completely disappear from your ears. The doctor is literally altering the physics of the patient's skin to tune their instrument in real time.
It is a remarkable, highly sensitive, tactile skill. And the doctor doesn't just sit there and listen to a stationary patient. The exam is dynamic. They use specific physical maneuvers to purposely alter the heart's anatomical position and manipulate the blood flow to accentuate hidden murmurs. For example, asking the patient to roll into the left lateral decubitus position.
A classic maneuver.
I mentioned this briefly earlier when we talked about the PMI moving. The doctor will ask the patient to roll partly onto their left side. Why do they do this? Because gravity, combined with the shift in the chest cavity, causes the heart to swing slightly on its vascular pedicle, bringing the apex of the left ventricle physically closer to the chest wall. If a doctor strongly suspects a left-sided S3 gallop, an S4, or the quiet rumble of mitral stenosis, but they can't quite hear it when you are flat on your back, they will roll you onto your left side. They will place the bell lightly directly on the PMI and listen. Sounds that were completely inaudible just seconds ago suddenly become clear.
And then there is the specialized maneuver for detecting aortic regurgitation. The murmur of a leaky aortic valve is a high-pitched, soft, decrescendo blowing sound. Because it happens during diastole when the pressures are dropping, it can be incredibly faint and easily missed. To hear it, the doctor must employ a very specific sequence. They will ask the patient to sit straight up, lean their torso slightly forward, exhale their breath completely, and then hold their breath out.
I said this in my notes. It's like a yoga pose, specifically designed for cardiology. Sit up, lean forward, breathe all the way out, and freeze.
Exactly. Every step serves a physical purpose. Sitting up and leaning forward uses gravity to bring the aortic outflow tract physically closer to the anterior chest wall. Exhaling completely pushes the air out of the lungs, effectively removing the dampening, sound-absorbing effect of inflated lung tissue between the heart and the stethoscope. With the patient holding their breath in this position, the doctor presses the diaphragm firmly down the left sternal border. If the clinician does not take the time to perform this specific maneuver, they may completely miss the diagnosis of a leaking aortic valve.
It is an incredible, beautifully choreographed sequence of events. The doctor is actively manipulating gravity, respiration, tissue density, and the acoustic mechanics of the stethoscope to run a full diagnostic suite on your engine. using nothing but their hands, their ears, and their knowledge.
It is. However, this brings us to a fascinating and somewhat sobering extrapolation mentioned in the later chapters of the text. While these auscultatory skills are undeniably beautiful and historically foundational to the identity of the physician, there is a well-documented, undeniable decline in physical examination skills at all levels of medical training today. The art of listening to the heart is highly vulnerable to the crushing time constraints of modern clinical practice and the rapid, overwhelming evolution of technology.
Right. It takes time. Why spend 10 minutes in a busy clinic trying to listen for a faint grade 1 blowing diastolic murmur by making the patient lean forward and hold their breath repeatedly when you can just wheel in a portable ultrasound machine, squeeze some gel on their chest, and look at the valve yourself? The text specifically mentions that point-of-care cardiac ultrasound, often called POGO-CS, is fundamentally changing the landscape of bedside assessment. Doctors can now look directly at the valves opening and closing on a high-definition screen in real time, measuring the exact velocity of the regurgitant jet.
It is undeniably a powerful, life-saving tool. Bedside ultrasound provides immediate, direct anatomical visualization, effectively replacing much of this intricate auditory and tactile detective work with concrete imaging. But the transition does raise profound questions about the evolution of the physician-patient interaction.
It's incredible to think about. We have spent this entire hour diving as deep as we possibly can into the unimaginable complexity of the cardiovascular system. We've talked about the mechanical doors of the valves slamming shut to create the symphony of the lub-dub. We've mapped the intricate electrical pacemaker that coordinates the whole dance down to the millisecond. We've explored the fluid dynamics that push the veins in your neck up and down, and the actual physics of how a doctor stretches your skin to tune a stethoscope. The human engine is an absolute masterpiece of biological engineering.
It truly is a masterpiece. We just spent a significant amount of time learning about the intricate, highly sensitive, and deeply human art of auscultation, palpation, and observation skills that have been painstakingly honed and passed down by physicians over centuries. But as we just discussed, with the unstoppable rise of bedside point-of-care ultrasound and digital diagnostics, are we at risk of losing the fundamental physical-human connection of the medical exam? If doctors eventually stop using their hands to feel for the buzzing thrill of a murmur and stop using their ears to hear the subtle, struggling rhythm of an S3 gallop, and instead only look at glowing screens and read automated reports, what subtle, holistic, immeasurable clues about our overall health might be lost in the translation to digital pixels? It is a shift from feeling the patient to scanning the patient. This raises a vitally important question for you, the patient, to mull over the next time a doctor places that stethoscope against your chest.
Something profound to think about the next time you are sitting there, hearing that crinkly paper on the exam table, waiting in the quiet. Thank you for joining us on this incredibly deep dive into the hidden language of the heart. We hope you walk away feeling empowered and amazed by your own machinery. Keep listening to your body, keep questioning, and keep learning. We will see you next time.